Sunil, are we live? Sunil.
We are live, sir.
Good evening, everybody. Welcome to second Journal Club meeting by Maharashtra Ophthalmological Society and BOA. And today we are going to discuss a very important topic of posterior capsular rupture in mature cataract. And we have stalwarts in this field. And over to you, Dr. Vaishal, to introduce the speakers and the flow of events for today's webinar.
Sure. Thank you so much. I, at the outset, thank the faculty and the presenting team. And today we have a very elite and a distinguished panel. Dr. Sandeep Nagvekar is a very well-known cataract and a refractive surgeon, and he does not require any introduction. He is my senior colleague in Mumbai, practicing at Santa Cruz, and very knowledgeable person. And it will be a great treat to have him today bring out the good points out of this presentation today. Dr. Sambaresh Srivastav is another young, dynamic person who is at Raghudeep Eye Hospital, Jaipur. And I have heard him at a lot of forums. And he is a very natural knack on things. And he's got his own way of thinking. And let's hear both these faculties today. It'll be really a treat to watch both of them today. And I thank the presenting team from Lata Mangeshkar Eye Hospital, Nagpur, headed by Dr. Rekha Khandelwal. Madam, thank you for participating in the Journal Club. And without further ado, I would ask today's moderator, Dr. Parul Deshpande, who is running this Journal Club for so many years. Yet another Journal Club meeting. Parul.
Thank you, Dr. Vaishal. So today's article, as all of us know, is the risk factors for posterior capsular rupture in mature cataract surgery, a study of 1,302 eyes, which was published in IJO. So this would be presented by the Dr. Kinnari Shah, who is from NKP Sarve Lata Mangeshkar Hospital from Nagpur in ophthalmology department. And I have my co-moderator, who is Dr. Rekha Khandelwal, who will be moderating the session for Journal Club today. She's heading the Department of Ophthalmology in NKP Sarve and Lata Mangeshkar Hospital. She is currently involved in a lot of teaching activities in Maharashtra. So with this, I would request Dr. Kinnari to share her presentation. So Dr. Kinnari, can you share your presentation?
Yes, ma'am.
Yeah.
Is my screen visible, ma'am?
Yeah, it's visible.
Yes, Kinnari.
Yes. Good evening, everyone. First of all, I would like to thank the MOS committee and the BOA organizing committee as well for giving me this opportunity for speaking today. Today, I'll be presenting in the Journal Club. The title of my article is Risk Factors for Posterior Capsule Rupture in Mature Cataract Surgery, a study of 1,302 cases. It is an original article which was published by Ali Kellis et al. In the Indian Journal of Ophthalmology in December 2022. The impact factor of the journal is 1.84. Cataract surgery is the most common intraocular surgery performed worldwide. One of the major complications of cataract surgery is posterior capsule rupture, and its incidence is said to be about 0.2 to 17% as per the surgeon's experience based on various literatures. Various risk factors have already been identified for PCR in cataract surgeries. These can be divided into local factors and systemic factors. The local factors are sunken globe, narrow palpebral fissures, high myopia, glaucoma, pseudoexfoliation, traumatic cataract, and dense cataract, whereas the systemic factors are advanced age, dementia, disorientation, severe obesity, Marfan syndrome, diabetes mellitus, and systemic hypertension. A comprehensive preoperative evaluation and preparation is very important to prevent PCRs, and the authors have reported that there are no publications that have directly addressed the risk factors of PCR in mature cataract surgery. Hence, this study was chosen for the discussion. The aim of the study was to determine the risk factors of PCR in mature cataract surgery, and based upon that, to take necessary precautions that would help in reducing the surgical complications. Methods of the study. This was a single-center retrospective study carried over a period of 7 years from 2013 to 2020 at an eye clinic of a tertiary referral hospital in Turkey. The study was approved by the local ethics committee and followed the tenets of the Declaration of Helsinki, and retrospectively, the case records of the patients were scanned and analyzed. As per the study, mature cataract was defined as a completely opacified lens that prevented the red reflex from being visualized. Inclusion criteria was all adult patients belonging to either sex with mature cataracts, subjects of Caucasian origin, and preoperative vision of hand motion or light perception. And the exclusion criteria was of cases of surgery combined with cataract, such as trabeculectomy and vitrectomy, and lens-induced glaucoma. Clinical evaluation was done and baseline demographic data was evaluated. Preoperative slit lamp examination to look for pterygium, corneal scars, posterior synechiae, pseudo-exfoliation, and phacodonosis was done. Specific risk factors such as sunken globe, strabismus of more than 10 prism diopters misalignment, history of trauma, glaucoma, and history of vitrectomy were also evaluated. Anterior chamber depth and axial length were also evaluated, and the mean values of these measurements were retrieved from the patient's medical records. The surgical techniques undertaken were that preoperative pupillary dilatation was done with the help of topical cyclopentolate hydrochloride 1% and tropicamide 1% drops, and local anesthesia was given to all the patients either by the subconjunctival or subtenon route, and trypan blue dye was used for capsulorhexis. Type of cataract surgery was evaluated, whether it was phacoemulsification or extracapsular cataract extraction, and the eyes were then classified as complicated and uncomplicated groups according to the occurrence of PCR during the study. The statistical analysis was performed and the descriptive data was evaluated in terms of mean plus minus standard deviation values. Categorical variables were analyzed as per the chi-square test. Difference in the age of patients in terms of categorical variables was analyzed by the independent sample t-test. Final potential risk factors on development of PCR was analyzed by the multivariate regression analysis with adjusted odds ratio. Analysis was done using SPSS 22.0 program, and a p-value of less than 0.05 was considered to be statistically significant. The results of the study were that 1,302 eyes of 1,226 patients with mature cataracts were included. The mean age was found to be 66 plus minus 12.8 years. Phacoemulsification was performed in 83% of the cases, while ECC was performed in 16% of the cases. 1,207 cases were in the uncomplicated group, and 95% of the cases were found to be in the complicated group with PCR. 26% of the cases were performed by resident surgeons and 74% were performed by senior surgeons. And the intraoperative variables that were undertaken during the study were mentioned as 3.6% of the cases used iris retractors, 3.5% of the cases used capsule tension ring, and 2.2% of the cases, intraocular lens could not be implanted. Results of the studies. In this, the table 1 is showing the association between posterior capsular rupture and the systemic characteristics, and it was found that only advanced age was significantly associated with PCR, whereas gender and systemic diseases were not significantly associated. As per the multivariate regression analysis for the association between PCR and ophthalmological characteristics, it was found that history of trauma, glaucoma, strabismus, pseudo-exfoliation, small pupil, phacodonosis, and surgery type were associated with PCR. And as per the multivariate logistic regression analysis with the odds ratio, it was found that history of trauma, strabismus, pseudo-exfoliation, phacodonosis, and surgery type were associated with PCR. Discussion. The risk factors for PCR, as per the studies reported in the literature, were in agreement to the study in terms of eyes with advanced age, pseudo-exfoliation syndrome in small pupil, and history of trauma. Whereas those that were not in agreement with the current study were systemic diseases like diabetes mellitus and hypertension, local anesthesia without adrenaline, extraocular risk factors such as corneal opacities, shallow anterior chamber depth and long axial length, glaucoma, prior vitrectomy, asteroid hyalosis, and ECC rates were also found to be lower in the resident group as compared to the other studies in literature. A new factor which was reported for PCR as per the current study was strabismus, and no similar study was found that gave a statistically significant association for strabismus with PCR. The author's interpretation was that the most common factors associated with PCR, and it found that the highest association was of pseudoexfoliation syndrome with 48% in the complicated group. ECC surgery was 38%. Phacodonosis was found to have a 26% association, and strabismus and history of trauma both were found to have 7.4% of association. The author's interpretation in terms of the limitations were that this was a retrospective study design, lack of mention of the patient's cooperation during the surgery, the surgeon's years of expertise or number of cases were not included, and only Caucasian cases were included in the study. As per the MARI protocol, the study question was well defined. The sample size, the large series of mature cataracts was included. Inclusion and exclusion criteria was well defined. Study period was well defined, and it was a retrospective study. Mature cataract was not categorized into intumescent cataract, hypermature, and brown cataract. Secondary outcomes like post-operative visual acuity was not studied. The step of surgery when PCR occurred was not mentioned due to lack of data, and small incision cataract surgery method was not assessed or included. Statistical tests applied in the study were appropriate. The study has concluded that pseudoexfoliation is the most common cause of PCR in the surgery for mature cataracts. There is no other article currently on PubMed which specifically looks for the cause of PCR in mature cataract surgeries. Strabismus was found to be a high-risk factor for PCR in this study, and pseudoexfoliation was the most strongly associated risk factor. My interpretation of the study is that this study highlighted the possible risk factors to look for in mature cataract patients to avoid intraoperative complications. They could have categorized PCR based on intraocular and extraocular factors, intraoperative factors, and surgeon-related factors. And the presence of strabismus as a risk factor for PCR has filled in a probable knowledge gap for us. Thank you.
Thank you, Kinnari, for an excellent presentation. You have covered it very well.
Thank you.
So we begin with the panel discussion. Parul?
Yes, ma'am.
Yeah. So I would like to ask Sandeep sir about the study, what he thinks about the percentage of PCR in this study, especially in mature cataract. 7% they got in this study. Do you think this is a very high rate, or do you think with your experience, what do you think, sir?
So, if you look at this very carefully, this is a study carried out actually over 8 years, and there are different levels of experience of the surgeons who operated, right from residents who did about 16% of the cases, 1/6 of the cases were done by that, and then again by senior doctors as well. If you look at all the risk factors that have been, which have been attributed to the cause of PCR, a new emerging factor is strabismus. Now, actually, I'm not very sure about, I don't remember any PCR in my case where there was a strabismus cause. So I don't know whether they were referring to strabismus fixus. Was it a strabismus due to palsy? If Siddharth is here, he can highlight. And I don't know what is the reason why they have said that strabismus is the cause for thing. I mean, a mature cataract is a mature cataract, whether it be in the primary position or not in the primary position. And so there are other things that we have to look at, that the time when the PCR occurred is something obviously they did not have access to.
Yes.
Like, for example, they say that a small pupil was a cause, or an intumescent cataract was a cause. Now, for you, all you know, an intumescent cataract, you are very scared about, rexes running to the periphery. For all you know, the rexes must have been absolutely perfect, but either during phacoemulsification or cortical aspiration, PCR could have occurred. So we don't have a cause and effect, as far as the PCR is concerned. So in that sense, you cannot attribute that this happened because of phacodonosis. For all you know, they must have managed it very well and something else would have happened. But yes, I agree. Most of the risk factors that they have outlined are correct. Many of the other risk factors that have been mentioned are something which can be overcome with experience. an experienced surgeon would know that this is a thing. For example, I mean, just to say that when I look at a mature cataract, I look at it in only two ways. Is it a simple mature cataract without any other problem? Or is it a mature cataract which is intumescent? It has a shallow chamber. It has a non-dilating pupil. Does it have pseudo-exfoliation? Does it have phacodonesis? Does it have subluxation? So, you can tailor your things accordingly. So, yes, I agree. This is a good study, but definitely, there are some gaps in the study.
Yeah. Maybe because of the retrospective design, they could
Yeah,
not-
because of the retrospective design, and then records may not be up to date as far as everything is concerned.
today. Yeah. Do you think, sir, that the inclusion criteria are very wide in this study and they should have excluded pseudo-exfoliation altogether in this study? And then taken because it itself, pseudo-exfoliation is a big...
Yes, it's a big thing. Yeah, but then I guess you cannot have mature cataract and not include that. So basically, yes, I agree. But then you see the incidence of pseudo-exfoliation was also not very high. If you go to see the number of cases that were there. I mean, there were, I think, 1,150 single eyes and 76 bilateral eyes. They haven't mentioned the incidence of pseudo-exfoliation. But even in pseudo-exfoliation, it's not that a high proportion of pseudo-exfoliation had PCR. It was high, but not too high.
In fact, the chances of zonular dialysis may be a little higher than
Yes.
PCR.
Exactly. It is
Yeah.
the zonular dialysis which changes
yeah.
the ball game, completely.
So I think, sir, what they should have done is that they should have talked about a vitreous loss instead of a PCR. So what they meant either was a vitreous loss in patients with pseudo-exfoliation, because if you look at some of the other studies, when they talk about pseudo-exfoliation and a complication in a cataract surgery, they talk about vitreous loss. They never say it is a PCR. But this is a study where they have said that in a patient with pseudo-exfoliation, there is a PCR. And what we see in the other studies is a higher rate of vitreous loss in a patient with pseudo-exfoliation. So there they never mentioned about PCR actually. So I think probably what we see is more of a zonular dialysis with a secondary vitreous loss and not a PCR. So that is probably a conflicting result which they have really not talked about. Dr. Samresh, your comments also.
So again, this was a very interesting one, and I could briefly read it between the clinics, but it was very insightful as to a couple of things. One, the incidence of PCR is quite high, in considering mature cataracts, but also to be understood that it's an 8-year retrospective study in a tertiary center with a lot of residents. So I was expecting this PCR rate to be resident related, but it turns out that the PCR rate with residents and senior doctors was the same. Which is very very weird to see, because a senior doctor with years of experience will not cause that much of PCR. So what came to my mind is they've not really, even in retrospective study, they would have classified the cataract and the comorbidity, and they never associated that to the consultant case, because I'm guessing the consultants would get much worse cases than the residents during surgeries, but that was not factored in. So the data got skewed, all the residents got to become the better surgeons and the senior doctors got the blame for PCRs, and the whole equation got equated, which was not right, I guess, because it's not possible.
Another interesting thing, Samresh, was that when ECC was, attempted by the senior surgeons, they had more PCRs than when the residents were doing that. I mean, it's partly true because of what you have. Or lack
I think
of
I don't blame them, sir.
Sir, I just had...
if we do an ECC, we have more PCR.
So, Dr. Samresh, I had one thing. They said that fellow physicians. So, was it that they had a fellow, the way we have in our programs, that they have residents, there are fellows, and then there are senior consultants. So, did they really talk about the senior consultants, or they're talking about fellow consultants, who are just a step below the normal consultants,
Yeah, or just a step above the fellows.
Yes, above this thing. So I really don't know, because when I was doing my fellowship in LVP, we had the fellows, the fellow consultants, and then the senior consultants.
Yeah.
So I don't know whether they really talked about senior consultants or a fellow consultants here, So that could probably may say that, okay, they were also not very senior, but yes, they were definitely senior than the residents.
Yeah, because
Yeah.
Data does not correlate. Yes, please, madam. Go ahead.
Yeah, they have mentioned that our residents were observed closely when they were operating, and that's why their ECCs had no PCR. That's what they have claimed in their discussion, basically. So,
Yeah, and I don't know why they did not consider SICS, no, ma'am?
yeah, that was another point. But maybe we also do planned ECC in cases where they are difficult cases. We plan, like Sir said, that endocapsular, we might have to keep the anterior capsule in certain cases. Like we used to do in our little olden times, that planned ECC where we used to do endocapsular rhexis and try to, where the high risk cases, we can implant IOL over anterior capsule. Maybe that is the reason they have not included SICS. That is what I thought.
So, Dr. Samrish, your comments, or sir, your comments, Dr. Sandeep.
Yeah.
Yeah.
On,
So do you think why they have not included SICS instead of ECC? You know, because ECC nowadays, even I don't remember of doing it for a long time. If we are not able to do a phaco, we usually go towards SICS, the manual SICS.
But like corneal opacities and all, maybe they are planning ECC. That can be the reason.
No, but also the setting is in another country. It's Turkey, and we don't know the SICS caliber of the country because not all countries are doing quality SICS the way we are doing in India.
Possibility, yeah.
Possibility. Yeah.
We have Siddharth here.
That's
Siddharth?
Yes, I am here.
Yeah, Dr. Siddharth, two things we wanted to know. Obviously, Dr. Sandeep also asked you that strabismus in view of PCR. And second thing, your comment about this whole study as far as the statistics is concerned, I think we've lost.
So even I was wondering why strabismus. So now I am there.
Yeah, okay. So we have Dr. Sengupta also. So I think Dr. Sengupta also can comment later on. Yeah, Siddharth.
So I don't know why strabismus was included as a risk factor to begin with, because one of the principal ways when you do a modeling in logistic regression analysis is that you are supposed to choose your independent variables very carefully, because otherwise you will end up with such results which you are not able to explain. So there has to be a commonsensical approach to putting a variable as a risk factor. To begin with, why was strabismus put as a risk factor? That is the big question. What led them to believe that strabismus can be a risk factor for PCR when they are doing a cataract surgery under local anesthesia, where they are probably giving a block and they are immobilizing the eye. And even if they are not doing it under local anesthesia, when they are covering the other eye, even if it is a mature cataract, it is going to take up fixation if it is got PL positive. So I don't see why strabismus should be a risk factor. I think it is just by chance that it has come, statistically significant. Otherwise, there is no reason why it should be a risk factor. Although I am very pleased that now all the mature cataracts with squint will be first preferred for squint surgery, and then the cataract will be done. But I don't agree with that conclusion. I don't agree with the conclusion. Secondly, again, it's a very big retrospective study and a lot of data mining has been done. That is the problem with data mining. When you try to take out some significant factors from a large pool of data, you are going to find some things which are significant just by chance. Okay, so that is the thing, because they have studied so many factors. Might as well put the color of the shirt of the patient and whether the patient was wearing earrings or not, and then sometimes you might get significant. So I don't agree with the conclusion that strabismus increases the rate of PCR by 15 folds. So that doesn't make sense to me. Probably Sabyasachi can talk about it.
But Sengupta, can you have the comment on the article?
Yeah, so I wanted to share a couple of statistical.
Yeah. You can share your present.
One second, I'm just.
Yeah, share your screen. Yeah. There is a.
Yeah, I'm able to see.
Yeah, okay.
You're able to see my screen right now?
Yes.
Okay, so a couple of things. One is how to interpret logistic regression, or what is logistic regression. So I'm assuming that there are a lot of people want to know that. So what is a logistic regression here? What it really means is that when you look, there are many types of regression analysis, and the prime reason for doing a regression analysis is to adjust for confounders. So I'll tell you a little bit about what they are, but generally logistic regression is used when the outcome is binary, that is yes or no, like a PCR. Did it happen, yes or no? So when you have an outcome, so even when you're doing your own study or a thesis, think about when your outcome measure or your primary outcome is a binary outcome, you could do logistic regression, and the output comes in terms of odds ratios. So these are 3 odds ratios which I have highlighted. So odds ratio of 1 means there is no increase or decrease risk or likelihood of that event happening. If odds ratio is more than 1, that means there is a higher chance of that event happening. Say, for example, it is 1.64. How you interpret that is you will say that the chance of PCR happening is 64% higher. So when it's more than 1 and it's less than 2, you call it 64% higher. If it is 1.94, you call it 94% higher chance. When you have it of 2 or more, you'll say 2.3, so it's 2.3 times higher. So here it is 5.7, which says if there is strabismus, the chance of PCR happening is 5.7 times higher than if there is no PCR. Right. So this is basically a simpler way of telling people that, it's a little easier way of understanding, and you can account for confounders. So that is generally why logistic regression is used. Let us look at this table of association between PCR. So this is a complicated group of 95 and uncomplicated group of 1207. So when you look at pseudo exfoliation alone, so there is 46 in the complicated group. So 46 out of 95 is 48%. That complicated group, there are 288, which is roughly 24%. So, so this 48% and this 24%. So this doesn't mean that there is 2 times higher chance, So, this 48 is 2 times 24 is 48, right? So it is, based on this, you can't say that there is twice the higher chance. That times comes only when you do odds ratios. Also, when when we are talking about all these, there is a lot of overlap, isn't it? Because so pseudo exfoliation, small pupil, and phacodonosis will happen all together. So a lot of this pseudo exfoliation could have small pupil as well as phacodonosis. So does this pseudo exfoliation mean only PXF and no small pupil, or no phacodonosis? We don't know that, right? So it is likely that all of these are all sort of, so this small pupil and phacodonosis are a subset of this 46 size. We don't really know, right? So this is 12 and 25. So 37 out of 46. It's possible that they are all the same. So, so statistically, these are called interaction terms. So when, both are sort of the same thing, so roughly. So pseudo exfoliation, the main reason why it causes, leads to complications is because the pupil is small and because there is phacodonosis. Right. So if there is pseudo exfoliation with a well dilated pupil and no phacodonosis, it really behaves pretty much like, at least as close to an uncomplicated case as possible. So from a statistical point of view, we call this interaction terms. Again, surgeon and surgery, like Samresh brought up a very valid point, where the experienced surgeon is looking like a bad surgeon. But so again, there is an interaction term here, isn't it? So the surgeon and surgery, where ECC is the bad ECC or the difficult cases might be assigned to the experienced surgeon, right? So again, there is an interaction term here. So from a statistical point of view, these things need to be sort of analyzed better, which they have not given us. And lastly, this is that multivariable logistic regression, where all these factors have been figured into. But like Siddharth was saying, you could put the color of the shirt and others, you could do that. But then, the number of covariates or the number of independent variables, we choose that number, maximum number is based on the number of events. So here there are 95 events or 95 PCRs. So you can choose about 9 independent factors which will influence that PCR rate. If there were only 60 events, you could choose 6 factors. If there are 30 events, you could choose 3 factors. Something like that. So that is generally how this is called a best fit model. Best fitting means you choose only the number of variables which, or these independent variables which you think are likely to influence that outcome. So I very much agree that strabismus is, probably not necessary to be in that table, even if it is showing statistical significance, because, we can't have we can't have an explanation for that. And, for all if you remove the strabismus, all these odds ratios will change. They will change dramatically. So the strabismus should have been removed, and, these odds ratios would have been making a lot more sense, where you would see small pupil would become, say, 3.3 times more risk, So the small pupil would likely become significant if this strabismus was taken care of or removed. So then this, choosing this model is really important, and the best fit model, which is not only statistically best fit, but also clinically best fit, should be chosen for your regression analysis. So these are some of the things. So what we covered is when to do logistic regression, how do you interpret odds ratios, and then that direct comparisons can have some confounders driving. So we need to do logistic regression and the best fit model and how to choose it.
Thank you, Dr. Sengupta. Dr. Rekha, ma'am?
Yeah, I think it was beautifully covered by Dr. Sengupta. It could be just pterygium, and it could come as a factor for PCR, which we all know that it cannot come as a factor. So it has come the same way. I think what he has pointed out is correct. Another, I wanted to ask Dr. Samresh, do you think we should have a better design to look for PCR? What do you think? What should be the better design to look for PCR? Do you have any?
I think if I were to do a study like this, to do a prospective study, because you don't know how many you will get and where you will catch the surgeries. But I think a very important thing is proper documentation, preferably using electronic records now, because it's easily retrievable. But more importantly, documentation and record what stage and what level of expertise was being used. I think this study would have made a lot more sense if they had videos of these.
I think we are losing you, Dr. Samresh.
In
We are
this
not
document.
able to hear.
Am I audible now?
Yeah, better.
Am I there?
Yeah. You're there, but I think your voice is not very clear.
I'll shut down my video while I'm.
You shut your video, yes.
Yeah.
So is it better now?
Yeah, better.
Yes.
Okay. So what I was saying, rather than doing a retrospective file analysis, what would be better is to do a video series analysis, and then come up with data from that at all, from a retrospective series, rather than this. This is what I would probably do.
Probably that would also answer our question at what point we had PC rent, at what the technique and what angle, I mean, whether it was at irrigation aspiration, whether it was IOL injection. So that will also define at which step there was PC rent, and that will be a better study, as he pointed out correctly. Right, Parul?
Yes, ma'am.
Yeah.
And even
I just wanted to put a point
yes.
that in this study, when we are talking about the PCR, there is no mention about the rexes being complete, regular, circular, or how it was, which is very relevant for a PCR. If there is
a lot of intraoperative factors have not been really clearly mentioned in this study.
Absolutely. So that is very relevant, whether the rexes had extended or not.
So probably their primary outcome was just
done. So making a mention of the rexes would have been very, very important.
See, they have mentioned only pre-existing factors.
Yes, yeah.
They haven't mentioned
intraoperative.
Intraoperative events are not mentioned at all.
Yeah. They have just mentioned they have used some devices and pupil dilating devices and all.
Yeah.
They have mentioned.
They have only I
mentioned.
think talked about primary outcomes. They have not looked at any secondary outcomes. So they may have data, but they have not just declared any of the data. So the intraoperative
mentioned about the dilating devices, iris hooks. In those cases, there is a high chance of PCR.
Yeah.
They have mentioned that.
Oh.
One point regarding squint, actually.
Yes, sir. Yes, sir. Actually, all the panelists, I was going to ask only. Yes, sir.
Ask me. I'm just going to ask others. Regarding squint, actually, isn't it that there must have been some retinal pathology because of which there is a high chance of PCR and vitreous loss?
So my take on this,
high myopes usually do have, we have seen it.
Yeah.
So in the literature, we have not seen that patients with squint and hypermature cataract have more chances. But once the patient comes with squint and cataract, obviously we know that there is something wrong in the retina also. So probably that may have been the reason for high chances of PCR in patients with squint. This is my opinion, but it's open for discussion from the experts.
I think that's a very valid point, sir. In continuation with the same, their anesthesia was mostly using subtenons or subconjunctival. And a patient with no fixation with a mature cataract has a high chance of PCR in any case, because they're moving the eyes and they cannot fixate. So with this strabismus, maybe it was diagnosed on table for all you know, because there's no documentation of any ESO or EXO or anything of, there's no correlation.
And they have mentioned 10 prism diopters.
So,
They
so
mentioned.
I think I'll have a question for all the panelists. When you have a mature or a hypermature cataract, how many people block the patient and don't use topical anesthesia? So probably everyone can reply. So we'll know, because being an experienced surgeon, I think most of us do not have a higher risk of PCR. So Dr. Sandeep, you're this thing. So do you block these patients or you do it under topic? So you have femtocataract, I understand, but if you have to do a femtocataract and you're doing a routine phacoemulsification, so in these patients, do you block these patients or you just do it under topical?
No, I just do under topical. Actually, depends on, I do check how cooperative the patient is for fixation. I make the patient lie down. I show him the microscope light, or even when he's on the femto table, I ask him whether he can see the light within the laser machine. And if he fixes well, I will go ahead with topical only. Yes.
Dr. Samresh, yourself, yeah.
So madam, I think it's for most of my mature cataracts, it's topical anesthesia with supplemental IV anesthesia to help them calm down. But for certain very dense black or red cataracts that do turn up, I do give a light block, mostly because if I have to convert, I don't want pain happening during extracapsular and under topical. But for 90%, I would say it's topical anesthesia.
Santosh, yourself, sir.
There are two factors. One thing is the grade of cataract, and second thing is the cooperation of the patient. If patient is cooperative, then maybe topical, and if the cataract is soft, then I will do under topical. But if cataract is grade 4, large nucleus, and patient is uncooperative, very old patient, then I will definitely block the patient.
Dr. Anagha, are you there? Vaishal, yourself, what do you do?
I agree with the panel that I usually do most of the cases under topical with the IV sedation supplementation and wherever required. But if the patient is very uncooperative, I would definitely restore to peribulbar block.
I don't know, in my practice, I always do a peribulbar anesthesia because in the mature cataracts, I'm always doing a block.
But there is nothing wrong in giving peribulbar block.
Yeah, I don't know.
Why we shouldn't give peribulbar block?
Yeah, I don't know. I am still not very comfortable in the mature cataracts because especially with the rexes run away,
There is nothing inferior in giving peribulbar block.
Yeah.
Nothing absolutely. It's just your level of confidence, If
there are two
patient is
factors.
cooperative, I think you can do it.
Patient's
Also, it's very
cooperation and your confidence, or maybe your comfort level, I will say.
Yeah.
Instead of confidence, comfort level.
But it's very important to judge the intralenticular pressure.
Yes.
I mean, you look for fluid
Absolutely.
vacuums. If you find that the capsule is flattened well with your viscoelastic, or even otherwise on slit lamp, if you can assess, then I think you can do things with a great deal of confidence, even if you're doing a manual rexis. I think it's also a thought block, isn't it?
Yeah.
There is a study, preoperative anterior segment OCT in hypermature cataracts.
Mature.
And they have graded it. Actually, I don't remember who has done that study, but anterior segment OCT in hypermature cataracts. And then you can actually predict whether you will be able to perform proper capsular rexis or not. And the capsule run away in which cases. And that prediction is almost correct because you can actually see the pockets of fluid inside the lens.
Absolutely.
Yeah.
I think a great point that Dr. Nagavekar sir brought about also with this point was not all white cataracts are the same. So, to generalize white cataract and PCR rate is, just playing it out too easy.
Yeah.
And sometimes, it's in my hands, particularly like the dense black cataracts are not as much of a worry as the young diabetic cataract, which has no fluid in the eye and a tense nucleus, which you touch and splits open like, like a bomb ready to explode. So so I think this article is very misleading in terms of generalizing it all.
Yeah. because also it has not graded different varieties of mature cataract, which we see often in our practice, like can be intumescent, it can be white, it can be brown, it can be black, it can be all sorts, hypermature cataract, Morganian cataracts.
Absolutely.
All these cataracts, it has not graded in that way.
Dr. Mandar, if
although
you
the
could give
series
your
is
comments.
Yeah, so mature cataract is a completely different proposition, a completely different beast, no doubt about it. But apart from what has already been said, one more factor which we need to look at is the corneal endothelium. And particularly so if you're talking of a mature cataract with a very hard nucleus. And that is one thing which one has to look carefully on the slit lamp and judge whether the endothelium can sustain your phaco energy. And probably then you might, if you feel the endothelium is not very good, or if you feel the endothelium may not sustain the phaco energy, then either you go for the small incision surgery, or what I would do is, of course, use a high molecular weight viscoelastic to protect the endothelium. And I don't give peribulbars very often. I would rather go for parabulbar, the posterior subtenance anesthesia, which in most cases is pretty much good enough to give the akinesia and anesthesia effect, and you can do your surgery quite comfortably.
Yes. So I think from Dr.
Serious
Sam-
segment OCT study is done by Professor Titial and Namrata Sharma madam.
Okay.
And that was published in 2021. I'll just share in.
They have done it for even posterior polar cataracts.
Yeah, they have done it for all types of cataract, but especially for hypermature cataracts, and that they have graded also, and the risk factors.
Yeah.
So can we have Dr. Sandeep and Dr. Samaresh telling us that?
Lahane sir, welcome sir.
Sir is not audible. I think
I'm traveling, and thank you, Vaishal. I just got late, but please continue.
Thank you, sir.
Thank you, sir.
So Dr. Samaresh and Dr. Sandeep, can we have some tips for all the surgeons, the newcomers as well as this thing? So how should one go about in a mature cataract, mature or a hypermature cataract? So what precautions and what important steps that they should do so that they do not land up with complications? Dr. Samaresh, yes.
Yeah, you can start.
I'll start. So in my hands, what works best is a thorough preoperative evaluation. Again, to choose which patient to block on, it's always better to block because patient's cooperation is always a key because there's no fixation target for the patient to see. The second is I like to calm down these patients using IV sedation. If you have a good anesthetist, I like the use of small incisions. So I make my 2 side port entries. And I finish, or 3 side port entries, and I finish my rhexis under a trypan stain with a good heavy molecular weight viscoelastic, preferably like a Helon or a viscoadaptive like a Helon 5, because I don't want collapsing happen and the rhexis splitting away. And once my rhexis is complete, and then I make my main incision, because your main incision is the leaky wound. And if you're trying to do your rhexis through a main incision and your chamber keeps on collapsing, your rhexis might run away peripheral. So I think it's in my hands making a rhexis first, maybe a smaller rhexis after decompressing the nucleus will work wonders. And before I do a phaco, I can obviously extend the rhexis so as to not chew up the rhexis when I'm doing a phaco. And what else? What works in my hands is also the use of good control parameters. So please match your phaco, if you're doing a phaco, to your tip and sleeve, to your incision size. And the use of bimanual controlled IA over coaxial. Again, the lesser you use the main incision, the better it is. So these are the few tips that I think are, once your rhexis is through, half the battle with the mature cataract is done. Then it's only a matter of breaking it off. And I avoid hydro. I don't hydro any mature cataract at all because I don't know where the capsule lies, posterior capsule.
So what do you use, a 26 number needle bent, or you prefer a rhexis forceps through main? So obviously you said side port, so micro rhexis forceps or a bent.
So I make 3 side ports, madam. I make 2 on the side and 1 because I'm a temporal surgeon. I make my temporal incision also using a side port. I make the first puncture using a cystotome, which is only bent in one direction. So I don't bend it downwards as well. And with the same cystotome, I puncture the capsule and I suck out the fluid so as to cause a decompression. Once that is done, I give up the cystotome and I start with a microrhexis forceps and I do a hand exchange. So I start with my left hand and then I exchange with my right hand. And then I finish a rhexis slowly. And if I feel the chamber is collapsing, I top up more viscoelastic. But again, like I said, not all viscoelastics are the same. So at least if not for anything else, for these cataracts, a good high molecular weight viscoelastic, preferably a good sodium hyaluronate, will sit like a paperweight and it will prevent the whole chamber from collapsing backwards up. And once my rhexis is complete, then I convert that small side port into a main incision with a 2.4 knife.
Dr. Sandeep.
Yeah, I think Samresh has covered up most of the points. Again, the careful examination on the slit lamp to look for those fluid vacuoles. You don't need an OCT. And if you find that there is intumescence, if you find that the anterior-posterior length, or thickness of the lens is quite a lot, then you would expect that there's a lot of high intralenticular pressure. So as Samresh said, I would not make the main incision. I just make the side port. I just nick it and aspirate from there itself. After that, I may just use the needle to create a flap. And once I've done that, I will continue. Very often I do a mini rhexis first, decompress it even further, then aspirate and go ahead. But the rhexis is not all it. What I would want the juniors to know that remember many of these white cataracts also you have huge dense brown nucleus inside. So when making your incision, at least as a junior, I would advise you not, if you're doing a phaco, to make a posterior limbal incision rather than a clear corneal incision. And don't make the incision too long, because if you're going too long, then you're entering so much and then dipping inside. So that causes folds in the cornea. So make sure that your incision is posterior so that in case of a PC rent and you want to extend, it becomes easier to extend the incision along the limbus rather than when you are clear corneal. So pay attention to the direction of the phaco probe as you're going to go inside towards the depth of the nucleus, which might be quite thick. This one point, saves Parul a lot of trouble later on, because if you've gone too anterior and you're going down into a deep nucleus, very often that pressure over there is responsible for causing a PCR. Also, it becomes easier to handle the nucleus, go to the periphery and create either a horizontal or a vertical chop by doing a posterior limbal incision. I think that's a very important thing in mature and hypermature cataracts.
The other
thing
point
is the
which I
same.
want to
Give a
ask
comment.
is,
Because
I wanted to ask one more point is the method of phaco fragmentation, because in these different kind of brown cataracts or white cataracts, what is your preferred phaco fragmentation technique?
Correct. Now, see, as far as white cataracts are concerned, if the nucleus very often is very brittle, Vaishal, very brittle.
Often brittle.
It cracks quite easily. But it is those hard browns which are a problem. And there I prefer to do a stop and chop. Very rarely will I go into total chop, only because of the lack of visibility. While I might do a total chop in cases where I see a red glow. When I don't see a red glow, Vaishal, I would prefer to make the trench first, split it into two. Once I start seeing the red glow, then it's easy to chop. So
very beautiful point highlighted by you. This is a very relevant and an important point.
Dr. Lani sir is around. I think he does a lot
Lani,
of
sir, please give your comments, sir. How would you deal with a mature cataract, sir?
No, I heard both Samresh and this one. Basically, what they said is true. But when you are doing any mature cataract, you must see that mature cataract is what type of cataract. If it is intumescent, then you will have to deal differently. Here you will have to just nick and remove that fluid. You can have a small rhexis and then you can have a second rhexis after removal of the fluid. Now, if you are dealing with the hypermature cataract where it is a shrunken type of cataract, in that case, the nucleus is always harder one. And in such situation, it is very difficult to do the rhexis because there is a fibrosis also. So you will have to use the forceps and do the rhexis. When you are going to the nuclear cataract and in the nuclear cataract, if you are going to chop, I always say that chopping in nuclear cataract, though there is a Nageswara saying, if it is you can say glow, then you can chop. No, I will always say, there may be or may not be a glow. You should go for the stop and chop. 2 pieces, making 2 pieces, half of the nucleus is always better in the nuclear cataract, and that always helps. Secondly, when you are doing the both type of cataract, that is a mature cataract and nuclear cataract. In mature and nuclear, your rexis should be slightly larger. Your rexis, if it is a small, then that small rexis, you don't know what happens. When you are making the pieces, the rexis gets tear, this PC get tears, and you feel you are not done anything. But that small rexis has teared the PC. So your rexis should be larger. And another thing is, you should have a better experience. Yeah? You might have seen so many cases. You have done proper cases. After that, only you should touch the nuclear cataract. Cortical cataract, yes. Once you do the rexis, you are through. So for the rexis, yes, you can use the sodium hyaluronate or whatever the thing, and you can use the forceps will be better than the needle. So in the cortical cataract, the rexis is important. In the nuclear cataract, the stop and chop is important. So, and your experience will help you there. But if you chop there, sometimes chopping is not possible. So, if you are you can beginner or learner, or you are doing the cases, then better is to go for the stop and chop. Thank you.
Thank you, sir. Thank you
I
so
just
much.
had one question, Vaishal. So, if is it better to use a torsional phacoemulsification or linear phacoemulsification with some parameters that you can, deal with these hard mature cataracts? Because I use a torsional phacoemulsification, but there are people who talk about phacoemulsification with Venturi system and with using burst, and so any experience with the panelists, what they would advise?
Beautiful question.
Torsional phaco. I'll go for torsional phaco actually.
Okay.
Because it has more cutting power, number one. Number two is there is less release of molecules, means oxidative stress is less to the endothelium in torsional phaco. And the beauty of torsional phaco is that it cuts the nucleus when you are coming backwards also. While in longitudinal phaco, it's only unidirectional. It cuts only in one direction. While in torsional phaco, it cuts even when you are coming back. So it has beautiful power of cutting. And there is no thermal damage also. So I will prefer torsional phaco.
Dr. Samresh?
Madam, again, it depends on the cataract. Like Nagavika sir said, white brittle cataracts are, like amazing because you land up in the OT and you realize that your day is done and it's good. But those dense cataracts, very dense cataracts, I tend to use a combination of both longitudinal and torsional in the same surgery. So while I'll have my phacoprobe on 60% torsional, I'll have a 30% longitudinal also, because more often, because the nucleus is so dense, the phaco tip gets occluded and you can hear that occlusion sound. And occlusion is bad when you're doing a nuclear removal because your tip is getting heated and you're landing up with the wound side burn because no aspiration is happening. So that longitudinal throws away the fragment like an intelligent phaco and it keeps on emulsifying it. So I think more important is the fact that when you hear an occlusion happening when you're doing a fragment removal, either manually disassemble the nucleus or add a little bit longitudinal over the torsional. So as a combination, you will never have 100% occlusion on the tip, on the phaco tip. So again, it depends on the cataracts, but I tend to add on a little more longitudinal if the cataract is like a black or a red cataract somewhere there.
So Parul,
Yes,
same here, when I'm doing trenching and these dense cataracts, I'll do a combination of torsional and longitudinal because my Centurion allows me to do that. But when I'm doing quadrant removal, as Samresh would agree, then torsional is enough, most of the time.
I think the more important thing is whatever machine we use, I think the more important thing is to have full occlusion when we chop and to avoid full occlusion when we are removing the fragment.
Another important point is that tip. There are special tips available like the Cobra tip for these brown and hard cataracts. And I have been using a 0-degree tip most of the time on a Venturi system. So the whole phaco-dynamics is different. Like in a 0-degree tip, if you use a torsional, the torsional won't be that effective. So I use usually a longitudinal with a horizontal and a vertical chop combination. And that works very well in my hands with a 0-degree tip or a Cobra tip. So that is another way or an approach.
You use burst technology or you use those hyperpulse technology? Any any difference? Because I don't understand these things very well.
See, basically to impel into the nucleus and hold it well, that is the most important thing. So there is a strategy where people trench a bit and then try to hold the nucleus well. Or if you want to give a burst, you can give a burst and it can impel into the nucleus. Holding in the hard brown cataract is very important. Otherwise, the chop will not occur properly. So the holding into the depth of the nucleus, not superficial. If you are superficial, the nucleus will not crack well. So that's why the relevance of burst or trenching before then you go for a chop.
Actually, cutting power increases with 45 degrees and there is no cutting with 0 degree. 0 degree holds the nucleus frame. Yeah. So for holding it is 0 degree.
So you mechanically chop
for cutting
it.
It has to be 45 degrees. So
Yeah, so
45
probably-
degrees mini flat tip is the tip for torsional phaco. So you have to use 45 degrees mini flat tip for torsion. Yeah.
I think, sir, we are almost.
There is a one question.
Yes,
May I
sir.
come in?
Yes, sir.
May
Yes,
I
Yeah,
come
yes,
in?
sir. Please comment,
Yes,
sir.
sir.
Basically, I think I agree with all of you. But see, torsional and longitudinal phaco, it is very difficult to purchase. If you are talking to the people who are a newcomer, how they can purchase Centurion? It is not possible. Or they can purchase Venturi. See, for the people who are newcomer, we must teach them that any basic phaco, you can do any type of phaco multiplication, but when you are purchasing, always remember the stroke length. If the stroke length of the phaco is good, then in that stroke length, you can operate any type of case. And about the, you can say the longitudinal and the torsional intelligent phaco, yes, definitely that works very well when you are using that. Like a tip also, 0 degree tip, like he was telling, it holds, and if it is a 45 degree, it cuts. But whenever we are teaching, we must teach basic things also, and then we should go ahead. What we do always, we teach the things which nobody can do, and then it happens that it is very difficult to. See, don't say like that. In any phaco, if there is a torsional thing is not there or longitudinal thing is not there, you can do phaco emulsification. It is possible. And only thing is that whatever you are using, so here you can use 15 degree or 30 degree tip instead of 0 and 45 degree. And that middle way will help you for both. Also for the, you can say, hold, and also for the, you can say, trends also. So whenever you are doing phaco emulsification, your experience is more important than burst mode or any other mode. So these modes are there, theoretical. Practically, it is very difficult to use these modes. But yes, they are definitely useful when you are doing maximum phaco and you have got such type of machine. But if that machine is not there, all modes can be used by your experience. So experience is more important, and whenever you are doing, you see the phaco emulsification by a surgeon, and accordingly you should go ahead. So that is what I want to tell you. Thank you.
Thank
Thank
you,
you
sir.
so much, sir.
Vaishal, I think we are almost.
Yeah, we have. It was
Just
a
one last
very
question
nice.
to 1 minute, Vaishal. One last
Yeah, yeah.
question to all the panelists. Will you do planned manual small incision cataract surgery in hypermature cataracts? This is open to all the panelists.
Dr. Samresh, you start with.
So man, I'm not a great SICS surgeon. So in my hand, it's either a phaco or an ECCE. Because I'm not done an SICS in the last 12 years. So I may not be the, so for my preference is phaco, number 1, or ECCE, number 2.
Dr. Rekha, ma'am?
I can do SICS or planned ECC, both.
Dr. Sandeep, sir?
So for me, it is phaco almost 95% of the time. But if I have a very hard black cataract under that white exterior, and I know that this is going to be very tough for me for the phaco, because and you want to preserve the corneal endothelium. Remember, most of these black cataracts come in very old people. The endothelium is compromised. I'm not going to waste my phaco energy and burn his cornea out. I would go for a small incision cataract surgery, which fortunately I've still kept in touch with. and I can manage it. Make as large a rexes as possible, and whatever be the size of the nucleus, you can extend your frown incision and take it out very nicely, and you will have a clear cornea the next day.
So despite having a femtocataract you're talking about?
Yes, despite having a femtocataract.
Yes.
Because
So this is a very good take-home message, actually.
cataract that I have makes a very good rexis. I don't get an Argentinian flag sign anymore, but you still have to break that nucleus. And remember, in a mature cataract, the femto does not penetrate. So you're not getting that advantage, So very often it is still a hard rock that you have to crack. And I do grade 5s also phaco quite easily. But if I have that gut feeling that this is going to be tough for me and I'm going to lose a lot of sweat and glucose and his corneal endothelium is not good, it is better to go for SICS and finish the matter quite nicely. And quickly also. You save a lot of time.
Dr. Mandar, sir?
Yeah, I agree with what has been said, especially what Dr. Nagvekar said. Most of the times it's phaco, and phaco. But of course, there are those rare instances where you would rather do something like a SICS or even an ECC, where you feel that either the endothelium is not good or there is even a slight amount of phacodonesis. In those cases, I would rather prefer to do a ECC or an SICS. One quick point which I would like to mention, and this is from my personal experience, that oftentimes these mature cataracts have a very fragile anterior capsule, and one should not take it easy even after putting in an IOL, because it has happened a few times that while doing an removal of the cortex or removal of the visco at the end of the after implanting, the anterior capsule just cracks, it just gives way. Luckily, this doesn't cause any damage in the posterior capsule, but this point needs to be remembered that these mature cataracts have extremely fragile capsules. It is much thinner. The tensile strength is much less than in an immature cataract, and you should not be relaxed till the patient is really out of the OT.
Dr. Annaga?
So PC is very thin in these cases, so they are almost very fragile.
Lana, sir?
Lane, sir.
Your opinion about SICS?
What question was asked was about the hypermature cataract. You will do SICS or not? See, in hypermature cataract, if the patient is you can say shrunken type of cataract, in such situation, the capsule is very fragile, posterior capsule also. And if you go ahead with the phaco, sometimes it is not possible to do the phaco. So SICS will work good. Second thing is about the nuclear cataract. If your endothelial count is less than 1500, then and the patient's age is more than 75. In such situation, SICS works better than phaco, because here the second day cornea is clear. Otherwise, you will have to tell the patient for 8 days that there is a this you have put a year, and after that you will see. So every day we'll have to just tell something to the patient reasons. It is better to do SICS, and patient will have a good vision. Secondly, surgeon will also be very safe when he is doing SICS. So SICS is not a bad surgery. For your knowledge, I will tell you, we operate 70 lakh cataract in India, and out of that 70 lakh, 45 lakh cataract today also done as a SICS, not as a phaco. And those people are also they are also getting the vision. So SICS is not an inferior surgery. Of course, phaco is superior surgery, but SICS is surgery, and that definitely saves the surgeon and also the patient's cornea.
Thank you, sir. Vaishal, I think we should end up here.
Yeah. So I'll ask Dr. Sumit Lahane to give the Thanksgiving. Dr. Sumit.
So we have not discussed about zonular weakness in mature cataract.
Now we crossed our 100.
Hypoglycemic you have become.
Yeah.
You have lost your endothelium.
Cataract is an endless topic.
Over to you, Sumit.
Thank you all. Thank you, MOS, and thank you, BOA. Thank you, Santosh sir, Anaga ma'am, and most importantly, Parul ma'am and Vaishal sir for putting all this together, and our panelists for being here and guiding us very nice case presentation, very nice paper presentation, and a very good discussion. Hope this will be there on the online platform so people can see it again and again. And I would like to thank everyone for being here and spending their Wednesday evening with all of us. Thank you again for
Yeah,
the
I thank Dr. Nagwekar and Dr. Samresh. The discussion was brilliant. The points which you brought out were very relevant and practical. And thank you, Lane sir, for attending the Journal Club meeting. Great.
Thank you,
meeting.
Sabyasachi, also for showing how
And
to
Dr.
analyze.
Sabyasachi and Dr.
Thank
you
you,
were-
everybody.
Kesarwani.
Thank you.
With a
And Dr.
surprise.
Siddharth, excellent analysis by Dr. Sabyasachi and Siddharth.
So I
Thank
would
you.
like to thank Dr. Rekha also because she was my co-moderator and she did it really very well. And Kinnari had presented very well. So I think with this
Thank
we,
you, ma'am. Thank you, sir.
yeah.
Thank you.
Thank
everyone.
you. Bye-bye.
Thank you.
Everyone.
Good night.
So next Journal Club will be after 2 months, right? Dr.
Yes,
Vaishnav?
That's right.
After 2
That's
months.
right. Yeah.
What will be the topic like?
So we've
That
not
will be
decided.
later?
I don't know. Let us
Decide.
know.
We will shortly put it up.
Yeah.
Sir. Yeah.
Good.
Thank
a
you.
lot.